Thank you so much for having me. So my role at Guy's, at our National NF1 Complex Centre, is as the lead nurse. I've been there 9 years now. Time flies when you're dealing with wonderful people like yourselves. But obviously, as part of my nursing role, you know, quality of life is the utmost of what I do. And as some of you probably can understand, pain management is a lot of my conversations with people that I have day by day. So very excited to be here to chat to you about that. And always very keen to hear from people in the audience as well. So firstly, pain management. Just a quick question to the room. If you were asked if you could have a life without pain, who here would go for it? Pain-free life. Yeah, 100%. I don't want pain. We don't want pain. But unfortunately, pain has a purpose. You know, it's not just there for no reason. Pain is there to protect us. You know, there is a condition that causes people to not be able to experience pain. And unfortunately, the people with that condition, you know, are in lots of injuries. Because if you think about it, pain is there telling our bodies when something's not right. So it has a purpose. And I put up the definition just so we all are on the same page. It's an unpleasant sensory and emotional experience associated with actual or potential damage. And I think that's really important to note. It's physical, but it's also emotional. And so when we're managing pain, we need to keep that in mind, you know. Purpose of pain, it's there to protect us if an injury happens. So if you think about, you know, if you're walking along, you trip over, you roll your ankle's going to be on pain. Why? Because it's telling your body, stop walking on that ankle. It's damaged. It needs to rest. You know, it's there telling your body that something's not right. Long-term experience of pain links with memory. So, you know, as we're growing up, as children, you know, we'll maybe, you know, go near the oven, even if our parents are telling us not to, and touch the oven. Oh, it's hot. And so that goes into our memory to say, oh, actually, I'm not going to touch the oven. That's hot. I'm going to learn. And so part of pain comes into our memories. It's really important. And that then affects our behavior as we're growing up. And this is something to also remember when we're dealing with pain management, is our memory of pain can affect our behavior. So acute pain, this is, you know, if you think about short-term pain, like I said about rolling your ankle, that would be an example of acute pain. You know, you might have rolled your ankle or broken it. And so the treatment of that is going to be very specific to that particular thing. So if you think about something that's acute, you've had an acute injury, what kind of things might you do to help that injury? Rest? Yeah, 100%. You're in pain, you've hurt something, you're going to rest it. What else might you do? Yeah, ice or heat, exactly. There's inflammation there, you want to ice it, get that inflammation down, 100%. Or yeah, heat, if it's muscle damage, you know, again, maybe your muscles are in tension, so you use the heat to try and get them to relax, to release. Yeah, anything else?
Medication, so paracetamol, ibuprofen.
Exactly. So this is why you're in the front, because you got all the answers. So yeah, so the medications you might use, paracetamol, ibuprofen. Maybe if something's really gone on, you might use something a bit stronger like an opioid, like a morphine or something like that. Ones that you might have heard before. If you've had back pain, you know, sometimes you might have a short dose of codeine, just again to try and help the muscles to relax and get through it. So something has happened. It's a clear, you were fine, something has happened, now you're not okay. So it's acute. It's happened very quickly, and it is telling your body that something's not okay. And so, as you've all said, they're really good strategies for how to deal with that kind of pain. The problem is when that pain then doesn't go away, when these strategies don't work and the issue doesn't resolve. And that's where, for a lot of people that I'm chatting to, who have maybe neurofibromas sitting on their nerves, causing the pain, with sometimes not a clear-cut way of sorting that out, we move into chronic pain. Now, if you think about with the acute pain management, some of those strategies are really fine for 3 months. It's fine to rest an ankle for 3 months. It might not be fine to rest that ankle for 3 years. Once you start heading over that acute phase, you're going to cause problems by using those same kind of short fix strategies over long term can actually start causing problems. So that's why when we talk about chronic pain, so pain that lasts kind of longer than 3 months, the way we deal with it has to change. And that's why, it gets classed as a disease in its own right. We have an entire team that deal, in our hospital, we've got an entire chronic pain team because it is its own issue. Regardless of what has caused that chronic pain, it needs specialists themselves who are used to managing chronic pain to be able to look after it. So yeah, like I said, it's over 3 months. And sometimes this pain, the chronic pain, it can't be easily explained. Sometimes, there is a clear answer, the broken ankle or something, but how about after that ankle is fixed? The bone's fine, but you still have pain in that area. Or maybe, a lot of people that I'll chat to have developed pain, we'll scan you. And when I first started working in NF, people would call me and say, oh, I want the results of my MRI, and I'd be so excited to be like, we've done a scan, there's nothing there. Isn't that wonderful news? And they'd be like, but Mary, I still have pain. Why is there nothing there? And I learnt very quickly that sometimes what I would think would be good news, there's no tumour, that's great. Actually, that's not helpful, because now we're left saying you've got these symptoms, but there isn't a structural change to cause for them. And, as we went past thinking about the definition of pain, just because there isn't a structural change, so nothing that shows up on the scan, doesn't mean that the pain itself isn't there. Because if you think about your pain pathways, they start in the head, they go down your nerves to wherever it is that you're experiencing the pain. We can't say whether somewhere along that line there is a dysfunction in that message. And sometimes that's structural, there's a tumour sitting on a nerve and we can say, oh yeah, it's pressing on the nerve, that's why the message isn't working. Sometimes there isn't something structural that's caused that dysfunction. And that can be the hardest type of pain to manage, because I have a lot of people say, I've spoken to this person, they say there's nothing there and it's all in my head. And that can be really dismissive to hear. But actually, we want to say your pain is real, whether it's structural or not. We're going to manage the pain in the same way, because it's the pain that we're dealing with, But unfortunately, I can appreciate it's really hard when there's no clear answer for why it's there. So quickly, just my safety netting as an NF nurse. If there is a lump, that is inoperable, we've done the scan, we've seen, yes, there's a neurofibroma there, it's causing this pain, it's very clear. Unfortunately, sometimes we can remove the lumps, and that's great, and people can get really good results. Sometimes when we remove a lump, the pain doesn't go away, or we make the pain worse. And that is, I'm sure some of you might have experienced that yourself, and that's a really hard decision to make. And so then we have to manage the pain, that is now there. But safety netting, if a lump becomes very painful, is growing rapidly, is changing texture or causing weakness or numbness or pins and needles longer than a month, please get in contact with your healthcare professional. Sometimes these lumps just grow a little bit because they do, but sometimes it is because something very serious is going on. So please, if you get these symptoms, please get in contact with someone who knows about NF. So how do we treat chronic pain? It is a very difficult thing to treat, as I'm sure some of you might have experienced, and it requires a whole body approach. So we need to think about your physical the structures of your body. We need to think about your mind, how it's affecting your mental health, and also how it's affecting you socially. Are you still able to work as much as you did before? So we have to take in you as a whole person, because unfortunately we can't cure it, but we want people to be able to maximize their quality of life. So lots of ways that we can do that. The treatment obviously depends on intensity of pain and what the pain is doing to your quality of life. For some people with intense chronic pain, maybe it's intermittent. So sometimes they can just go about their day-to-day life, and then they'll have a flare-up of the pain, and we'll manage that flare-up, and then it will dissipate, and they'll be able to go back to what they're doing. For some people with chronic pain, the way they were living life before, it's not possible anymore. And so we need to work with them to be able to maximize, like, what can you do? And how can we, keep you doing what you value, what you enjoy, while also still making sure that you're getting the support you need to be able to get through the difficult times of pain. So the different strategies we use that I'm going to quickly cover is self-management, medication, physiotherapy, psychology, and surgery. And before you all start panicking at me about psychology, I'll get to it, but please bear with. We're not saying it's all in your head, we're just saying chronic pain affects all of you and it can affect how you feel. And that's important to address as well. So self-management, there are loads of resources, online free resources that you can get to, that you can do at home, by yourself. You don't need to be on some massive waiting list to chat to someone about pain. You can access these resources straight away. And they're really good. So there is the Physiotherapy Pain Association. I'll put all the links right at the back of the last slide. So if you just want to take a photo of the last slide, you can do that. Pain Toolkit's a great one, has different videos on there. I think it's 12 different tools. Flipping Pain, which I quite like, but got really good videos on there as well, and same with Retrain Pain. Retrain Pain has very short little sort of almost like slideshows that you can go through that addresses different things about pain and managing pain in very bite-sized presentations. So it's quite a good one if you sort of want something to dip in and out of and you just want to explore the topic a bit more, then Retrain Pain is a great one to look at. Medications. So we mentioned some medications earlier. Paracetamol, ibuprofen, maybe codeine, morphine, all those kind of ones. They're really great for short term. Over a long period of time, that's not really what they're designed for, and sometimes they can actually start causing more problems than what they're trying to mask. So we move into a different type of pain medication. Does anyone know any names for some of the nerve painkillers? Start up the front.
So naproxen,
yeah,
gabapentin, pregabalin. So
that's
yeah,
good.
those.
I'll repeat them. Yeah, exactly. So that was gabapentin, pregabalin, naproxen. Maybe some of you have heard of amitriptyline as well, and nortriptyline. Yeah, so these work very differently to your ibuprofens and your paracetamols and those sorts of things. And sometimes when you start these medications, it can be hard to get your mind around how they work, because they work very differently to your acute pain medication. So when people, you have pain and you think, oh, I'll just take some paracetamol, and then I expect in like half an hour that my pain's going to improve, right? But if you start on something like amitriptyline, it might be that you're on it for 2 to 3 weeks before you start seeing a benefit. And that's the important thing to learn. If you take nothing away from this talk, please take away that if you start on a nerve painkiller, you must take it as prescribed. So whether that's every night or if it's 3 times a day, whatever it is, that you are taking it regularly, because they work as getting sort of a level in your body. One of our doctors describes it almost as if you've got a bathtub running and the plug's out, and you want to fill your water in the bath to the right level. And so you have to have, this is not very
energy or climate change efficient, but so just bear with me for this picture. To keep that water level for your bathtub at the right level, you have to have the taps constantly running as the water keeps going. It's like that with these pain medication. You need to have the taps running to keep it at the right level in your body. And sometimes it will take 2-3 weeks to get that right level, but sometimes it might take learning what dose is going to be right for you. So you might start, and it's so variable, this is the problem. You might start on amitriptyline 10 milligrams. I know some massive men who are on amitriptyline 10 milligrams, and it knocks them out. It's too much for them. They can't cope, and that's fine. But then I might have someone who's, much smaller, and they'll be on 100 milligrams of amitriptyline, and it doesn't touch them at all. So we cannot predict how these pain medications are going to affect you. And that's why it's such an important partnership to work with your healthcare provider to try and find the one that's going to work for you. Because unfortunately, they do often give you quite a lot of side effects. I don't know if anyone's tried them or wants to yell out some of the side effects they might have experienced. Drowsiness, dizziness, yeah. Brain fog, yeah. Any others? Dry mouth as well. Some people say, I just feel like a zombie. So for some people, those, the first 2 weeks that you start taking a nerve painkiller is when you have the most extreme side effects, which is really hard when I've just told you that the pain relief probably won't kick in until after 2 weeks. So it is a really difficult time to say, I'm going to commit to this. I'm going to commit to 2 to 3 weeks, aware that I might feel really rubbish, but let's just see if it is actually going to work. And that's why we'll start you on a really low dose. So if you start on something like gabapentin, there are some people that will be taking, 3 tablets 3 times a day. That's, it's a lot. But when we start you on the drug, you only start 1 tablet every night, for a couple of days. And then you build it up because the side effects can be, really hard to live with. So it is important when we're thinking about this that we understand this is a long process. These drugs can be very effective, but it is trying to titrate of finding out what works for you. And also, that might be different to people in your family. Again, you might have, a family member who's on these drugs. They work great, and then you try them for your own pain, and they might not work for you. So it is trying to find out what's going to be the best thing for you. And also that, for some people, they say, well, actually, I can go up to this dose, and it really helps my pain. But then the side effects, I can't cope with the dizziness, or I can't cope with the drowsiness. And so sometimes it means putting it down a bit to have just like, okay, the pain's a bit better, not 100%, but it's better, but the side effects are manageable. So it is trying to find that balance. And this is why, pain management is, we want to get a whole team around you looking after you, because it's not simple. Okay, so pain medication is helpful, but has its own challenges, as I've just said. So another member of our team is our physiotherapist. Why? Because it's really important that you're able to maximize what you can do within your physical limitations. And, we want to make sure that you're doing that in a way that is safe as well. So that's why a physiotherapist is someone who is trained in understanding your body to make sure that you're not doing things that are dangerous, but you're also not getting deconditioned because you're trying to guard the pain. And so it's really helpful to have someone, in your team. They might be a nerve-specific physio, or they might just be a musculoskeletal physio, but someone working with you to make sure that you aren't going to lose function that you could have kept and maintained. And also really important to note is when you start any form of exercise, but especially if you are coming back from recovery, maybe you've been in hospital for a while and you've gotten deconditioned. When you start an exercise program, it's very common to feel an increase in pain for a short amount of time when you first start. And so again, it's important to be keeping conversation with your physio to make sure that it's an acceptable amount of pain. It's expected that, oh yeah, that muscle's going to be a bit sore if you're working on it that way. That they're working with you in that and making sure that you're not doing too much and actually doing damage. So again, it's about a partnership with that healthcare professional. Psychology, like I said, we're not saying psychology because we think your pain is not real or anything like that. It's that having chronic pain or having a chronic condition that is affecting your quality of life, affecting what you used to be able to do, affecting, what maybe you want to do and you can't do, that's going to affect your mood. And so it's really important that you have access to someone that you can, work through these things with. Especially pain psychologists specifically look at the fear, anxiety, other behaviours maybe around the pain. So for some people, if you have, I'll keep using broken ankle because it's simple. Say you broke an ankle, even though that ankle is now fixed and the doctor has said, yeah, you're fine to walk, maybe you've become really fearful about it happening again. And so you're not walking because you're really worried that if you do, you're going to get that pain again, you're going to be back in hospital. And so you just stop. You stop exercising. Physically, you could be exercising. The doctors have said it's fine. But it's because you now have a belief that that is something that you shouldn't be doing. So the psychologist will work with you around that belief to try and see if you can make steps to move forward to say, actually, it is okay that I'm walking. And so that's kind of their role, if that makes sense. So they're going to listen to you. What are things that you're believing that are stopping you from doing what you actually can be doing, and then helping you make steps to reach those goals. So that is their job. So if anyone says, maybe you should speak to a psychologist, please do not panic and think we're being dismissive. They're a really helpful member of our team to get you moving towards things that you value, that you enjoy, and improving your quality of life. And this is my very quick to show why the psychologists fit in the way they do, is because all of these things are interlinked. So how the physical sensation of pain links in with the emotions we might have about it. Maybe the pain came from something very traumatic, and so we have a lot of negative feelings about that. Maybe it's taken away a lot of things we really love. So you've got a lot of emotions. Then you have thoughts. So like I was saying before, maybe you're thinking, oh, it's not safe to do these activities. Maybe I'm thinking this pain will never end and I'm trapped. Whatever those thoughts might be, those thoughts are then going to also affect your behavior. So maybe you're not seeing your friends anymore because you don't feel up to it. Maybe you're not leaving the house as much as you used to. So all of these things are interlinked, and that's where having someone like a pain psychologist can be really helpful to kind of tease out what's going on and try and see how we can help you, do the things that you love to do in spite of the pain. A couple of psychology strategies you might have heard of before. Cognitive behaviour therapy, has anyone heard of these? It's a quite common one, isn't it? Can anyone quickly sum up what they think cognitive behaviour therapy is about? Yeah, go on.
So it looks at how you see something. So it could be, okay, my legs really hurt today, so I'm not going to go out with my friends. So it's changing that to say, well, actually, I really want to go out with my friends. Mm-hmm. And actually my legs might be sore, but actually I'll feel better if I do go out.
Yeah.
And I'll get this benefit from doing that action. So it's making you see things differently and see the positive side of things, rather than going straight to the negative.
Yeah.
And a lot of it is doing it yourself.
Yeah.
So it is you making those changes. You'll have homework to do from your sessions, looking at what's important to you and how you can achieve those things that are important to you.
feel like I should need to give you a mic. I just realised I've had to repeat all of what you just said, which is what Claire said was really good, which is, you might have, something that you really want to do that you're going to enjoy, but say, well, actually, I'm in pain, I can't do that thing. And the psychologist works for you to be able to challenge those thoughts and say, well, actually, if I do that thing, even though it's going to be hard with the pain, it'll be worth it because it's something I value, it's something I enjoy, and I'll feel better from it. So CBT, cognitive behaviour therapy, they believe that your thoughts affect your feelings and affect your behaviour. So they look at challenging the thoughts. You might have different thoughts about like what you're going to do, how you feel about things, and they say let's challenge those thoughts and see if we can change them. This works for some people. Who really like it. It works really well. It sometimes doesn't always work with chronic problems because, we can't change, like pain, we can't change pain. And so you might say, well, I can challenge those thoughts, but it doesn't really change the fact that I'm in pain. And that's where another psychology model called acceptance and commitment therapy has been gaining traction, because it says, well, actually, yes, you have that pain. We can't get rid of the pain, so let's say accept it, which doesn't mean embracing it and think it's wonderful. It's just saying this is not going to go away. This is now part of my life. So how am I then going to continue to do what I value, to do the things that I want to do, and take the pain with me? And like you said, still go out and see your friends, even though you've got the pain. So that's a very different style, if that makes sense. So you've got like CBT is challenging the thoughts, ACT is saying, is there, let's continue to move forward, and let it be there and not let it stop me from doing what I want to do. So when you see, so if you are offered to see a psychologist, it's a really good question to ask them. Are you a CBT psychologist? Are you an ACT psychologist? Because they're quite different.
A lot of people with NF will have ASD or ADHD as well, and cognitive behavioural therapy doesn't tend to work well with people with ASD or ADHD. So if you have either of those conditions or feel you have traits of those conditions, it is worth exploring other therapies.
Absolutely.
Because actually there can be quite a block there with regards to CBT. And it just doesn't work well, because if I use my youngest child as an example, if they feel that, they've got a feeling about something, that is their feeling.
It's going to be a lot easier than me having to repeat it.
So my youngest child has autism. They also have something called PDA, which is demand avoidance. They were offered CBT, but it was decided because when they have a decision about something, when they have a thought about something, that is it. So if it was, I don't want to go to the park, no matter whether you say to them, we'll go to the park, we'll get ice cream, we'll go to the toy shop after, we'll do this, we'll do that. It is, I'm not going to the park. So with pain and trying to change those feelings about pain, it'll be, I'm in pain, so I'm not going to do that thing, even if you offer me that it's going to do X, Y, Z for me. Because they're quite set in their mindset about things. So it can be really hard for a person with ASD or ADHD to use CBT, because it's hard for them to challenge those thoughts and their feelings about things. So if you or your child is offered CBT and you have ASD or ADHD, actually it's probably worth seeing if you can explore a different therapy.
Yeah, exactly. I think that's really important. And like you say, within the NF1 community, majority of people with NF1 are neurodivergent of some sort, so it is trying to find something that's going to work. There's no point doing something if it's not going to work. And same with like finding a therapist that you feel a connection with. I know with the NHS sometimes that's, there isn't that choice. But I've had a lot of people come to me and say, oh, I've tried this, oh, it didn't work, or I didn't get on with that person. I'm like, okay, well, is it that the psychology itself doesn't work? Which, if you're right, in the case of neurodivergence, it's like, it probably won't. But is it that, or is it that it was a person that you didn't feel comfortable with and you felt dismissed by, or something like that? Then, it's always worth trying things with maybe a different person or a different strategy, different approach. ACT is also very carefully and entwined with mindfulness, which is a strategy we use a lot in pain management, and that is about being present and helping our mind to be in the present, looking at maybe something else to try and distract our brains from the pain. Sorry, I'm just aware of the time I've been told off. But just quickly, pain management programs around the country. We have some NHS-funded pain management programs that are inpatient or outpatient based and use a load of different specialists coming together for a very intense short period of time to help you manage your pain. So at Guy's at St Thomas's, we have a program called Input. I know Bath also has a program there. So I'm not so aware of what's happening in the north because that's not the area I cover. But just to be aware, there are these types of programs around the country. If you have exhausted loads of different pain medications and nothing's helping, sometimes being able to go somewhere for 2 weeks and get a really intense review of what's happening with your pain with the psychologists, nurses, doctors, and physios and OTs can be enormously helpful. So just to be aware, those programs exist. So thank you so much for having me. You're actually going to have to listen to me after the break again. Apologies. But these are the resources. I'll keep them up there if anyone wants to take a photo so you're not having to like scribble them down. They're the ones that I would recommend.